Hello, hello, and good day to everybody who has joined here. So, a warm welcome to everyone present here to this webinar, which is moving towards an antibiotic smart community through the use of a novel indicator framework. This is being hosted by ReAct Asia Pacific. Just a few instructions before we begin. Please note that we'll be recording this webinar for internal purposes, and thank you to the speakers and the panelists for their consent to record. Also, the webinar is for 1 hour and 30 minutes, and I request all the attendees to please put in any questions that they might have to the speakers in the Q&A box. To begin with our webinar, we have Dr. Sujit Chandi, Director of ReAct Asia Pacific and Professor, Department of Pharmacology and Clinical Pharmacology at Christian Medical College, Vellore, India, giving an introduction to the webinar. Over to you, Dr. Sujit.
Thank you very much, Shruti, and my thanks and appreciation to all the panelists and the participants for being here with us. I think it's going to be a very useful and important session. So why are we here? Well, I think one of the reasons is that we all know that antibiotic resistance is a huge problem. We know some of the contributing factors. We know that it is a One Health problem, but we also know that we are very much responsible towards not just why it's happened in one sense, but also towards containing and trying to strategize on ways to actually contain the problem. One of the main thrusts in the world in the last few years has been the Global Action Plan and subsequently the quadripartite movement towards a One Health strategy. And one of the chief strategies has been to have national action plans in each country. And what has happened over the various years is that many countries have attempted many things, but it's always been difficult to involve all stakeholders, the entire country, different regions, urban, rural, different professions, different age groups, and the diversity sometimes makes it very difficult. Financing makes it difficult. And there's so many factors, barriers, and challenges. But one of the things that we realized as ReAct and as ReAct Asia Pacific quite a few years ago was that if things truly need to work in terms of AMR containment, antibiotic resistance containment, we need to involve the community. Now, what do I mean by community? Well, it could mean many things, but we often think of community as a place where people live together. But it could also be a group of people who have shared interests, a group of people who have shared practice, who learn from each other, a group of people who work towards a goal. Now, whichever country we look at, we know that many things work through communities. And if the community and their leaders have belief in it, often the community goes with that thinking. So it is only right that in such a complex phenomenon like antibiotic resistance, that we should be involving the community, not just with our national action plans, but with our regional plans, our state action plans, and even below, because every unit of the health system and development in a society often goes with the community. So it was with that kind of thinking that we thought, okay, let's try and involve the community in some way, engage with them, see what their problems are, but also how can we truly involve them in what we used to think was a very scientific problem like antibiotic resistance, when actually it's not. It's much more than a science problem. It's not just a bacterial problem. It is much more a societal problem. And therefore, we thought it's only right that we involve the community. And we wanted to see, whatever strategies we have, how does it work? Is it working? And that's when we thought of this indicator framework. And beyond that, to really, does it change things on the ground? And how can we involve these communities in this whole process? So that is the primary thrust of this webinar. But we also need to realize that there could be many other ways in which we should involve the community. many other ways which we are involving the community in many parts of the world. And therefore, this webinar is also a primary wake-up call to ensure that this thrust on the community remains if we are truly to actually contain antibiotic resistance in its entirety, in its complexity, in all professions, in all sectors. And so with that small introduction, I'd like to thank all those who are here, and especially those who are going to give their talks and the panelists, because I think these words of wisdom will truly go a long way, much beyond this webinar, to kickstart a true community movement in each of our areas, in wherever we belong to, in any of our professions. Thank you very much once again, and happy listening.
Thank you, Dr. Sujit, for that great initial talk. Now we have our first presentation for the day by Professor Otto Kaas, who is the founding director of ReAct in 2005. He's a specialist in infectious diseases and a senior expert at the Public Health Agency of Sweden. He has been actively involved in numerous European and international initiatives in the area of antimicrobial resistance, and is a member of the WHO Strategic and Technical Advisory Group on Antimicrobial Resistance. In today's session, Professor Otto Kaas will be speaking about the need for community mobilization around AMR and the sustainability of interventions at the grassroots levels. So I'll just share the screen right now, 1 minute.
Thank you very much. Thank you, Sujit, for your introduction. In fact, I'm very happy to be here and to make some reflections on this really critical need of involvement of civil society at large. You already alluded to a few things that I will also make a point in case of, but for sure, the fact that there was numerous years of political inertia has not been in our favor, and the real kickstart was as you said, the Global Action Plan in 2015, which spurred a lot of initiatives all over the globe, but primarily, of course, as you mentioned, the fact that countries were urged to develop their own national action plans, and they are all over the place. Most countries have an action plan, but we all know also the barriers that they're facing to implement this. It's a huge effort in a long-standing, sustainable way. It's about capacity, of course, human resources. It's about technical knowledge, but also, for sure, funding. So there is a struggle to make this work in the pace that the world needs. So next slide, please. I mean, there are numerous barriers. Science to policy is one. We are talking about a very scientific issue, a lot of terminology that neither politicians nor the public at large can understand really. But there are also different framings, and I can show you just one. The next slide is from one document from the Wellcome Trust. Next slide, please. Where you can see, you all know that we are talking about the ineligible climate change. There's a huge cost to economy and numerous deaths. We know the Graham study. There is numerous messages around, and there is not one message. It couldn't probably be one message because it's so broad. So we have to really develop the narrative according to the target groups in another way, I would say. Now we also talk about the silent pandemic, which is obviously true because it is a pandemic. And next slide shows another call to action in a way. This was from this year's inauguration of the ReAct Africa conference, where the Ministry of Health from Zambia told us that if community members do not understand the language we use when addressing AMR, we have done nothing. We have to have a user-friendly AMR communication. And the next slide shows another quote from another Wellcome Trust report. It's from a senior scientist at the Indian Council of Medical Research in India. Effective evidence-based communication is as important as scientific evidence itself, but we need more research to understand how to communicate. And he made the analogy with HIV and polio. And I think that is good, but we don't have the patient groups for because AMR, antibiotic resistance, is not a disease. So we don't have a pre-formed lobby or a pre-formed communication or advocacy groups around this problem. We have seen many more civil society organizations entering this area, but obviously we need to take a much bigger leap in engaging the communities. Yeah, and I come to some of that conclusions in the end. So next slide is again about the other barriers, policy or to implementation. Of course, we already mentioned the barriers that the governments face. And here I think the governments need to understand that if the community or the civil society at large is included as implementers, it will be speeding up the implementation of the National Action Plan for sure. The governments also face difficulties to find money, catalytic funding, which means that there will be short-term projects instead of a sustainable action. There will also be projects that are entering one pocket or the many areas that need to be dealt with instead of integrating it in a system, strengthening perspective in health, agriculture, and environment. So we have a long journey ahead of us, obviously, still. Next slide shows, in a way, which actors need to be included, and of course the government has the ultimate responsibility for securing access to effective antibiotics, which should be the end goal of what we are doing. But governments can't implement this top down with the scarce resources that are at hand. So obviously country ownership is key. All of society engagements is key. And civil society could have at least two roles. One, of course, is to make governments accountable, to tell them what is needed and point to where gaps are. But also, and primarily, I think this what we will discuss today is also to take part of the implementation. And support the implementation and engage in the neighborhood and in the communities, as Sudhit was mentioned in the beginning. And this is something that, in fact, has been called upon by the Interagency Coordination Group, which was a UN group, as many of you know, and I was very privileged to be part of that group, and we delivered our recommendations. You can take the next slide. Recommendations to the Secretary General in April 2019, where one of the recommendations is that the ICG calls for the systematic and meaningful engagement of civil society groups and organizations as key stakeholders. Has this happened? No, I don't think so. I think this is what we need to catalyze. I think we can see many more, as I said, many more groups that are engaged in the three areas of One Health, but it needs to be systemized much more, and it needs to be facilitated. What ICG was stating in the report, next slide please, in brief, next slide there, is that we emphasize the closer engagement of civil society is essential. That ICG, we noted that civil society groups have a particularly important role to play in the development of national AMR action plans and enabling citizens to become agents of change. We need to be grounded in bottom up. People need to understand what we're talking about. People must know what they can do and what they can do together. And again, we highlighted the importance of providing political, financial, and technical support to civil society organizations to enhance their engagement. This is a role that governments should take much more seriously, because that would definitely, in my view, support the speed that implementation can take place and share the burden and the responsibility of the implementation itself. Next slide, please. And this is my next. I have one more slide, I think. So this is from a paper that ReAct published last year in the Lancet Global Health, where we try to identify in brief the many components that need to be included in the implementation of an action plan in the health sector. And similar graphs can of course be produced for the other areas in One Health. But we have a lot to do. It's both AMR specific and AMR sensitive issues. Some are really long-term health system strengthening, like prevention, water and sanitation, vaccines program, but it's also about data generation and not the least awareness and behavior change, which I think is the key area for discussion today. How can we move up knowledge and understanding of what is needed and what is really it's about, and how important these precious drugs are for any health system. So having all this in mind and seeing it from the top, who can help the government to deliver on this? We have, since way back in Sweden, a very successful program where called Strama, where professional organizations, or professionals rather, doctors, pharmacists, microbiologists, have been funded and mandated in all the Swedish health regions to implement rational drug use to support the implementation of the plan and actions. And this has been successful. It's not very costly. It gives some mandate and some time for these professional groups that are working peer-to-peer to really convince everyone about doing better. And I think a similar approach might well happen in also engaging civil society organizations and civil society at large. If there is some catalytic funding and some more formal inclusion in the implementation of the National Action Plan, I think that would be make a difference. Next slide, please. So this is the last slide, handing over again to what we will be listening to today, and I really look forward to see how this handbook and the indicator framework could really engage individuals and communities in understanding what needs to be done, and also perhaps benchmarking across communities and even maybe even between countries, and be really useful for seeing how to move behavior change at the bottom-up level. Thank you very much for listening.
Thank you so much, Professor Otto, for that presentation. Next, we have Dr. Philip Matthew, external consultant, ReAct Asia Pacific, speaking on developing an indicator framework to measure antibiotic smartness as part of the Antibiotic Smart Community, and followed by Dr. Haifa Mohammed Ali, consultant at ReAct Asia Pacific, speaking on contextualized actions to plug gaps identified through the indicator framework. So the session will conclude with a summary by Dr. Philip Matthew, drawing on both their presentations regarding the Antibiotic Smart Community.
So thank you so much, Shruti. I hope I'm audible, and I sincerely hope that my screen is visible right now.
Yes, Philip. Yeah.
Yes.
Okay. Thank you. Thank you. I had some technical challenges in between, and suddenly things went blank. But so I'll be presenting about the Antibiotic Smart Communities indicator framework, the process of developing this particular indicator framework, which is actually meant to be a tool for benchmarking communities against each other, and also something meant to measure the antibiotic smartness of communities. And how did we define antibiotic smartness? So the background thinking for developing this indicator framework was that the national action plans, at least the first round of national action plans, mostly took a very top-down approach, with all the priorities and interventions decided nationally and then passed on. But then, especially in Asian and Latin American context, there is a greater democratic decentralization happening with more power and more resources being passed down the ladder, where the local self-government institutions become very, very critical in translating many policies into action. So we realize that all these top-down approaches need to be complemented by some kind of a bottom-up strategy where resources are raised locally, and also the priorities are raised locally for an optimal buy-in and also sustainability. So we were looking for a strategy because we didn't have any working models to actually refer to. So we decided that there are certain critical elements which should be a part of this whole process. We should be able to unpack the issue. We should be able to mobilize local resources, especially for the sake of sustainability. We also should be able to co-opt existing community assets. We should be able to engage the local self-government institutions. It can take the form, and the form and the shape and the size can be very, very different in each country, but there are definite local governance structures. And we should have some kind of a benchmarking for measuring success. So that's how this whole idea of an Antibiotic Smart Community project evolved. And the work started in 2018 by selecting a 11,000 strong community in the state of Kerala. And the choice was not, it was not a random selection. It was based on several factors, including accessibility and where we were located and all that. And the first part of it was actually a community survey using an adapted version of Eurobarometer 445. This particular tool has been used extensively by the European Commission to measure the level of awareness among its population. We had to do a bit of socio-cultural adaptation before applying it on the ground. Then we started this consultation with key stakeholder groups, including the leaders of the local self-government institutions. And then we had focus group discussions with various community stakeholders, stakeholder groups like women's self-help groups, which is very, very strong in that part of the country, farmers and community health workers, what we call as ASHA, accredited social health activists, which forms a link between the formal healthcare system and the community. The discussion was more to do with health and disease, their understanding about health, disease, infections, what are the possible messaging frames that they can possibly understand, and what are the ideal messaging channels that we can use to communicate with them. So all of that was compiled, and we also did a GIS mapping of non-domestic antibiotic use sites like clinics or retail pharmacies or poultry farms. It's a location with reference to possible environmental sources of contamination, all of that. So basically looking at whether any kind of clustering is there, and are they contaminating any larger environmental reservoirs. Then we started this work based on our understanding of the community and the community processes and the basic thinking about infections and disease and all. We kind of organized 3 expert consultations in 2019, one each with public health professionals, veterinary experts, and environment and development practitioners. We kind of gave them the existing SDG indicator framework to these experts so that they can go through every indicator in the SDG framework for anything which can measure antibiotics partners. And they were also asked to suggest new indicators, which was taken up and refined by the ReAct team. So at the end of this process, based on our community engagement exercise and all the knowledge and insights gathered through that, and also the suggestions from these set of experts, we could actually make an exhaustive list of 34 indicators, along with measurement strategies and how to categorize them and all of that. Then it was a prioritization exercise because frankly, it is not possible to apply a 34-point indicator framework. There are data gaps, there are feasibility issues. If it's very, very bulky, then community groups may not be able to actually take it up and apply. So the prioritization was done by a set of 20 global experts based on 3 criterion. One was the appropriateness of the indicator framework in measure, or rather the appropriateness of the indicator in measuring AMR specific or sensitive activities in local communities, the feasibility of measurement in low resource contexts, and also the validity of the indicator in detecting changes on the ground. We didn't want an indicator which cannot measure changes. If there is any specific activity directed at that particular domain, the indicator should be able to measure it and measure the change. And we actually came out with a list of 15 indicators covering health, hygiene, animal health, environment, development, and even there was a sprinkling of transsectoral indicators also covering multiple domains together. The indicators and the methodology for application was published as a handbook, which Otto had showed in the last slide of his presentation. Just to give you an outline of the final set of indicators, we had one indicator on hygiene facilities in primary and secondary schools in the community, proportion of households having access to individual household latrines, coverage of pediatric vaccines listed in the immunization schedule published by the nationally competent authority, percentage of access antibiotics in total antibiotics dispensed from a healthcare facility, proportion of healthcare facilities with written antibiotic protocols for syndromic conditions, over-the-counter availability of antibiotics in retail pharmacies, proportion of population using safely managed drinking water services, use of highest priority critically important antibiotics as per the WHO classification in farms, presence of veterinary healthcare facilities in the community, availability of veterinary laboratory services for disease diagnostics, educational initiatives in the last 1 year to increase awareness about antibiotic or biocide use among farmers, biocides and heavy metals being one of the other prominent drivers of AMR. Biomedical waste management systems in healthcare facilities, proportion of wastewater treated using any established wastewater treatment methodology, farm waste contaminating water resources in the community, and lastly, the use of chemical and synthetic pesticides, herbicides, and other biocides in farms. Each of the indicator can have a score between 1 and 3, and we had a definite categorization rationale also about whether the community should get a score of 1, 2, or 3. So the maximum score possible in this context is 45, and the minimum is 15. Just to show you an example of how we did it. So this is basically the proportion of schools in the area having gender-specific latrines with running water and hand washing facilities with soap for students. So there is a description attached to each indicator about how to measure it and how to categorize. And there is a recommended data collection process also. Some of them have a sampling methodology attached to it. In this case, it's basically an exhaustive sampling because usually communities are on the smaller size, and sometimes we have to include all of them in the sampling process. And there is a categorization recommendation also. And then there is a short description on the rationale for inclusion in the indicator framework. This particular indicator, how does it fit into the larger scheme of things regarding measurement of the AMR landscape? We actually went ahead and piloted this indicator framework in the Panchayat. Panchayat is a local government institution in the context of India that we selected in the state of Kerala. The total score was 34 out of 45. That was quite remarkable because this particular Panchayat is in one of the most affluent districts in the country, which has got the best socio-demographic indices among the whole of India. So that was possibly the reason why they were able to score very high at the baseline assessment level. To check for the feasibility of application, we piloted the indicator framework in 4 other parts of the country, in 3 other states, the state of Assam, Bihar, and Himachal Pradesh. Those who know the landscape of India, Assam and Bihar are among the poorest or the most socioeconomically disadvantaged states in the country. And Himachal Pradesh is a state with a very difficult terrain and very sparse population. So we wanted to check the feasibility in various socio-cultural and socio-demographic settings so that we are able to kind of make sure that there is a good ease of application and the access to data is not a challenge or a barrier while we are actually promoting this whole indicator framework. We got positive feedback from all the 4 places, with an average time required for application being around 15 days. I think 2 of the 4 places indicated some difficulty in obtaining prescription data from private clinics when trying to get data for the indicator on access versus watch and reserve antibiotics. We had the indicator framework reapplied in the community site in Kerala after implementing an action agenda. Action agenda essentially is a set of 12 specific activities which we implemented in 6 months. These activities were based on the initial application, the insights that we generated through the initial piloting phase for the indicator framework. And after these 12 specific activities were implemented over a period of 6 months, this framework was reapplied and the scores went up from 34 to 38. So we could conclude that this whole framework is sensitive enough to pick up changes on the ground. My colleague, Dr. Haifa Muhammad Ali, will take you through the action agenda just to give you a flavor of what we did with the community. Over to you, Haifa.
Thank you, Dr. Philip. So I hope my slide is visible. I'm audible?
Yes, you are.
Thank you. So for the sake of internet connectivity, I'll just keep my video off. So basically, I was speaking about how the indicator framework led to the formation of an action agenda, and then a few examples from the ground and how the changes have happened, like pre and post the results in the indicator framework, how it has picked up the changes on the ground post our implementation of 12 contextualized actions. So So essentially, we call this 12 contextualized set of activities as action agenda. And in the place of Malapurusheri in Kerala, India, the indicator framework scores that obtained were specifically used to design specific interventions. So they basically served as a point of entry for antibiotic resistance related community interventions, these indicator framework scores. And it has helped us in identifying where there is a gap and where we should be prioritizing to have these changes visible in the community. And also it gives an accountability for the actions on the ground. Besides, it helps in communicating. It helped us a lot in communicating the concept of ABR to the public. So the action agenda basically consists of 12 activities that were decided and co-developed in consultations with local parties. And the activities, it can be an AMR sensitive or AMR specific activity. And basically it has been, so the base for the action agenda would be the score that has been obtained from the piloting, the initial piloting that has happened in the community. So some of the factors that we kept in mind while we decided about having this action agenda would be, it should be something that helps in prioritizing the resources. It would create an avenue for multi-sectoral action at the ground level. It should also be something that prioritizes the need of the community. It has to be something that they want to happen on the ground or the changes that they want to see. And also it should be something that will increase the ownership and sustainability of intervention. That is like once we're out of that context, or once we have an exit strategy from the community, there should be some form of sustainability that will ensure that the change is sustainable and stays within the community. So it is basically meant to positively influence the score from anywhere. Like, yeah. So the activities were like I would just walk through a few activities that we had. So one was like, we initially had a competition, a design-centered competition that was conducted by ReAct Asia Pacific, where some of the PG, postgraduate students from Community Medicine Department in Pushpagiri Institute of Medical Science, they presented an application called Comrade. So Comrade applications were initially designed by the students for the healthcare workers, but we just try to take it a bit forward and we wanted to give it to the community. We kind of introduced the concept of antibiotic, the mobile application through which they could identify what is an antibiotic. And also we try to just show them how it can be used to identify the application and how we can identify whether it's an antibiotic or not. And also we try to just show them the idea of access, watch and reserve along with it. So basically the stakeholders that were involved in the activity was like local pharmacists, civil society in the area called the Grama Vigasana Samiti, and we of course we have people who developed postgraduate students from Pushpagiri Institute of Medical Science. So basically the indicators that we targeted that was like percentage of access antibiotics that is like dispensed in outpatient setting in any healthcare facility, if we could. Also, we were also just trying to see if we could figure out a reduction in over-the-counter availability of antibiotics in the retail area by ensuring them that this is an antibiotic that they're giving out. So basically just trying to improve the awareness of the people. And we were also trying to see if this could reduce the use of antibiotic. Another activity that we had was like targeting indicators on WASH. So we tried to collaborate with the local self-government and employment guarantee scheme, which provides employment generation to local community, and Kudumbasri, which is the women's self-help group in the area. So we gave them training and demonstration of soakage pit and compost pit construction. So that basically targeted on how the wastewater being transmitted, wastewater treated using an established treatment technology, or how the farm-based contaminating water resources in the community is being carried out. So these were like targeted intervention to specific indicators. So according to the government policy, there would be given a small allowance if they have an access to creating a sockage pit in the area. So in a way, we were trying to address this issue with the support of local self-government. Also, we were trying to emphasize on promoting sustainable farming practices in the area. So one such was like demonstration of biosecurity measures in animal husbandry. For this, we collaborated with the research center, which is associated with animal husbandry. And through them, we were trying to communicate and give sustainable farming practices and biosecurity measures to the people. So apart from that, we also were like trying to see mixed method practices in the community, if that could be encouraged, just to ensure that that household food security factor is being emphasized, like encouraging local production of food products, and thereby, encouraging non-use of chemical or synthetic pesticides or herbicides in the farms. So these are like small interventions that specifically targeted the indicator frameworks, certain indicators that we actually identified that is having a gap over the period. So the list actually shows those indicators from the 15 indicators where there was actually a gap, that is, which didn't have a maximum score of 3 out of 2. So one was with regard to the healthcare facilities, dispensing of aware classification, which should be 60%, but it was not, access category was not 60% either before or after, but we did try to focus on it. But on the other hand, we tried to focus on over-the-counter availability of antibiotics in retail pharmacies in the area, where we did see an improvement in the score post-intervention. We did see that there was a couple of pharmacists who were willing to take up forward this over-the-counter sale of antibiotics. Please consider the fact that in LMIC's over-the-counter sale of antibiotics is one of the key things that we have to address at a community level. So empowering pharmacists and empowering communities to identify the key factors which are necessary to combat was something we figured out by using this digital mobile application. Another thing, over the period, the highest priority of critically important antibiotics used in agriculture reduced. Those farmers who were actually using, we targeted them specifically and encouraged them to come up with healthier measures and approaches. So that showed a positive change. Another change, which we tried to go for a sustainable approach, was like educational initiatives on antibiotic use among farmers. In this case, we connected the community with the Nodal Center for Health, the research on crops and farming. So through that approach, the provider is being connected to the community, and this can be a sustainable result over the period of time, and they can come up with newer initiatives targeting antibiotic use. And in the initial approach, we had found one of the healthcare facility in the community did not have a proper protocol in waste disposal management, which, while being a collaborative organization in the activity, they have decided to scale up their activity, which showed an improvement over the period of 6 months. So it's not that the other indicators did not have an improvement. They did have an improvement, or they did have changes. Like, for example, the sockage pit demonstration that I mentioned earlier, that has created a change over the period of time, where the government has allocated money for over 60 sockage pit for the families with financial from poor financial background. So those kind of changes we did see, but these indicators specifically, they did have an improvement, which is reflected in the scoring criteria. So we did see an improvement in farmers who have there was a reduced usage of synthetic pesticides and herbicides, but we do have certain defined criteria that according to which it has to function to be scored. So it is not reflected, but then there were changes in the community. So there was a substantial increase, like from a score of 34 out of 45 to 38 out of 45 was obtained over a period of 6 months. And it should be also noted that this particular community has a good indicator comparing to all the sustainable development goal. So it is definitely a good change that we have seen over the period of 6 months through targeted interventions. And the lessons learned, we definitely learned that the contextualized actions and activities are like important. And more than that, I would like to hand over to Dr. Philip to take forward from here. Thank you.
Thank you so much, Haifa, for giving us a flavor of what we were able to do as a group in that particular community. So we had everything right from teaching school children on soap making to demonstrating soakage and compost pits to community members to specific interventions targeted at households and household groups. Kind of conveying them the whole idea about locally grown sustainable food production practices, locally grown nutritious food and sustainable food production practices. Now that we have a number of publications coming out of it, which included something on the messaging frames, rational messaging frames, and strategies for each community stakeholder group. We had a publication on the situation analysis, ideal situation analysis process for a community. We had the handbook for applying this indicator framework published. We had a handbook published for engaging local self-government institutions in the Indian context. So, and we have a couple of papers in coming up in peer-reviewed journals also. So at this point of time, we have managed to gather a lot of insights on how communities think about AMR, what are the ideal strategies to engage community groups on AMR. But what we need right now is a strategy on how do we convince the relevant stakeholder groups on prioritizing community engagement as a strategy for implementing national action plans. At least at this point of time, when second round of national action plans are being framed, what do we do at this point? And this webinar was an obvious solution in front of us. So one of the things that we have proposed is something called a community advocacy platform, which is a loose membership-based network where people or organizations, like-minded people or organizations who are interested in a bottom-up strategy for improving AMR action on the ground can come together as a pressure group, as an advocacy network, or even share best practices and learnings across each other. So the idea is to come out with a community advocacy platform, which we are planning to launch in early 2023, as some kind of a platform for like-minded people to come together and take the learnings from this particular project forward. And not just this particular project. There are several such initiatives across the board. I'm sure we'll be hearing more about the Responsive Dialogue project being funded and implemented by Wellcome Trust. The Community Engagement for AMR Network has published several strategies from different contexts on how they have done it. So there is a lot of learning there, but we need a common platform for sharing all this so that there is no duplication, there is optimal allocation of resources, and this whole idea of a bottom-up strategy is taken forward at some level. So we'll be sending out details about community advocacy platform and the structure of it and the rationale of such a platform, and how do we plan to take this whole initiative forward in subsequent emails, so that all of the people who are on this call are in the loop regarding what is our plan to take these learnings forward. Thank you so much for patiently listening to both of us. Over to you, Shruti, for taking the agenda forwards.
Thank you. Thank you so much, Dr. Philip, as well as Dr. Haifa. Our Agenda item is a presentation by Mr. Anand Balchandran, Unit Head, AMR National Action Plan, World Health Organization, Geneva, speaking on integrating community participation and mobilization into National Action Plan implementation efforts by using an indicator framework for quantification. So he has sent a recorded session, which I'll be playing now. And we have with us his colleague, Dr. Nienke Brunsma, from the AMR National Action Plan and Monitoring Unit of the AMR Division at World Health Organization's headquarters. She has joined us and will be happy to answer the questions on his behalf after the presentation. Thank you. I hope my screen is visible.
It is.
Good evening, distinguished guests, colleagues. Thank you for this opportunity to make a short presentation on behalf of the World Health Organization's AMR division. I would like to present on how WHO is moving towards a more people-centered approach to address AMR. As we know, based on recent studies, we can estimate that close to 5 million annual deaths are now associated with bacterial resistant pathogens. And 72% of them are linked to just 6 leading bacterial pathogens. So this problem, the problem of antimicrobial resistance, is even bigger than we had originally estimated just a few years ago. So what are we doing to address this? Countries around the world have developed AMR national action plans to address antimicrobial resistance in a multi-sectoral manner. And the annual surveys administered by WHO, but jointly developed by WHO, FAO, the World Organization for Animal Health, and UNEP as a new member. This particular survey shows that in 2022, based on the most recent data, 149 countries had developed national action plans, but very few of them, only 17% of them, are effectively implementing and monitoring their plans, and around 30 of them are implementing at a higher scale. So while the trends are very good over the past 6 years, there's been a number of countries implementing national action plans. What we have learned is that the implementation is very ad hoc, very slow, and driven by a few specific donor interests. And also, it is missing the interdependence between the various interventions. So moving forward, what do we like to do? We are planning on developing a more people-centered approach that would promote a much more coordinated and programmatic approach to addressing AMR. It will focus on the patient and the health system challenges and how do we address these, including through community initiatives. It will consider the interdependency between the various interventions through a specific patient or people-centered approach and pathway. Lastly, it will try to link health systems and pandemic preparedness strengthening efforts along with AMR. Finally, we need to make AMR more visible to policymakers. So we really need a face and a voice for AMR. It can no longer be a phenomena that's just focused on the pathogens or the drugs. So what is the people-centered framework that I talked about? It is focused on 4 key pillars of a person's journey, from prevention of infections, second to access to essential health services, 3, to timely and accurate diagnosis, and 4th, access to appropriate and quality assured treatment. These are the 4 key pillars across the patient pathway. And what we are trying to do is look at these 4 key pillars across the national and subnational level, at the community level, at the primary care level, and at the secondary and tertiary care facility level. So across these 4 levels, how can interventions be strengthened, and what are the challenges in these particular interventions across the patient pathway? Once again, prevention of infections, access to essential health services, timely and accurate diagnosis, and appropriate and quality assured treatment. In addition to that, we have 2 overarching, I would say, foundational elements. One is the governance, effective governance, without which AMR responses are not very effective. And secondly, the strategic surveillance information that is needed, that feeds data into this patient pathway to address the patient's journey better and to provide treatment better. And as we look at this patient-centered framework or people-centered framework, we would like to emphasize that our goal is to ensure equity in access and ensure quality so that people have quality treatments, quality medicines, quality diagnostics, and efficiency so that people have timely diagnosis, but also there is efficiency in terms of use of resources. This is an example as to how this would work. In the top layer, you have a people-centered challenges. In the bottom layer, you have health system challenges. So as a person moves from the prevention pillar to health services, to diagnosis, and to treatment, what we are doing is really analyzing what are the critical challenges people might be facing in each of these strategic pillars, and similarly, what are the health system gaps that needs to be addressed in each of these pillars. So we need to work very closely with the primary healthcare and health system strengthening teams, but also, more importantly, with community-based initiatives. Because in each of these pillars, we can see a clear role for community to get engaged. Either it's about hand hygiene and wash, or in access to health services, it's about access to basic primary healthcare services, or lack of insurance coverage, or lack of community health workers and staffing, or in terms of diagnosis, again, loss of follow-up due to extensive time it takes for lab tests, out-of-pocket expenses, no quality assured labs, etc. And for treatment, we again face the issue of safe and quality assured medicines and sharing of antibiotics and over-the-counter antibiotics, or no antibiotic stewardship policies in healthcare facilities. So all of these are examples that I'm providing to underpin the clear message that I would like to convey, that there are specific actions that the community can take to address AMR through very specific actions through this patient pathway. I was very pleased to see ReAct's data collection handbook, and I think we contributed in terms of providing some guidance to some of the indicators, but I'm very pleased to see the final document about Antibiotic Smart Communities, and I have highlighted 4 critical health-specific indicators on coverage for pediatric vaccines, on access antibiotics, as per the AWARE classification being available in healthcare facilities, antibiotic protocols in healthcare facilities, And lastly, over-the-counter availability of antibiotics. So these are some of the critical indicators ReAct has identified, and I fully align with these indicators because there is great need and necessity to address these issues. For example, in terms of water sanitation and AMR, there was a technical brief developed by WHO along with UNEP and FAO and WOA. And here, action area 2, as you can see in the slide, clearly highlights households and communities and the role they should be playing as well. What are some critical areas that should be addressed? And this is very well captured in ReAct's book. And also in other action areas like healthcare facilities and animal and plant production and manufacturing. Once again, ReAct's handbook and the data book really highlights some of these indicators. In terms of vaccination, I just came across these two studies just this week. One that clearly shows that in India, childhood routine vaccination coverage has been badly impacted by the COVID-19 pandemic. And so this is a clear area where this indicator that is there in the ReAct book needs to be addressed by the community in terms of making sure children get the full routine immunization coverage, they don't miss any doses of vaccines, and there is equitable distribution of vaccinations as well, not only in urban areas, but also rural areas. Secondly, I would also like to note that while vaccines are included in AMR national action plans, only in about 50% of them there are specific indicators, even though the global action plan monitoring and evaluation framework has already included some specific indicators. And I'm happy to see that there is alignment between the global M&E framework indicators and ReAct's indicators. In terms of regulation on antimicrobials, this is interesting because close to 90% of the countries say that they have regulations on prescription and sale of antimicrobials for human use and for the other sectors. So this is the good news that regulations exist, laws exist in terms of access to antibiotics and sale of antibiotics. However, when you look at whether these regulations are being enforced and whether there is a monitoring system to monitor the consumption and use of antibiotics, here we see major challenges. This data is from the most recent annual TRACS survey, the Tracking AMR Country Self-Assessment Survey, and we can see that a large proportion of countries are still in level A and level B from the graph on the left, which basically says that they do not have a system established as yet. So in the past almost 6 years, this has been one of the indicators with the least progress globally in terms of monitoring the consumption and use of antibiotics. This is linked to one of your indicators as well about the access antibiotics being prescribed. Hopefully it is at least 60%. That is the target being pushed by WHO and accepted by many countries and even exceeded by many countries. But to do this effectively, you need a monitoring system. The other one is about practical guidelines available in healthcare facilities. Here again, we see that this particular indicator on optimizing the use of antimicrobials has not done very well over the past 5 years. Again, it's quite stagnant over the past 5 years. And while countries seem to suggest that they have antimicrobial stewardship policies or a plan, it is not being well implemented in the healthcare facility level. So I was happy to see that elements of this is included in ReAct's Antibiotic Smart Communities, and communities really have a role to play in ensuring and in engaging and in encouraging healthcare facilities to make sure that stewardship policies exist. They can also support by increasing training for healthcare workers, supporting training for healthcare workers, but also supporting awareness campaigns at the community level about optimizing the use of antimicrobials, not only for human health, but also for agriculture, livestock, etc. So finally, I would like to thank ReAct Asia Pacific for inviting me to this webinar and for giving me some time to highlight some of my views and WHO's perspectives from the global level. I can't participate in the panel, but my colleague, Dr. Ninka Brunsma, will be available in the panel and can provide much more details about the people-centered framework that we are suggesting for National Action Plan 2.0 versions or even 3.0 versions. And we are now developing a core package of interventions across the people-centered framework. And hopefully there will be very clear elements for the community to get engaged and for ReAct to get engaged as well. So thank you very much for your attention. We need your support, and we cannot succeed unless all of us work together. Thank you.
I think that was a very insightful presentation, and I request all of you to type in any questions till now to the Q&A box. The speakers will be answering them in writing. Next, we have our panel discussion on the topic. Next, we have our panel discussion on the topic of community engagement and sustainable change in behavior for AMR mitigation. As panelists, I would like to invite Professor Otto Kaas, the founding director of ReAct, Dr. Nienke Brunsma from the AMR National Action Plan and Monitoring Unit of the AMR Division at WHO headquarters, Lucy McDowell, Senior Public Participation Manager at Wellcome Trust, Samuel Kimio, Executive Director at Africa Voices Foundation, and Tracy Murray, Policy Officer at ReAct Africa. The session will be moderated by Dr. Sujit Chandi, Director, ReAct Asia Pacific. Over to you, Dr. Sujit.
Thank you very much, Shruti, and thank you very much to all the panelists. We've heard some wonderful presentations and some very important points as we go towards the future with antibiotic resistance containment throughout the world and especially in our regions. So I'd like to just open this panel up by just initially asking Professor Otto one question about the report of the IACG, the Interagency Coordination Group, which you referred to in your presentation. It strongly recommended engaging communities and community stakeholder groups. And I think one of the broad suggestions was a strategy to improve the buy-in and sustainability of these antibiotic resistance interventions. In your opinion, how far do you think this strategy has moved along? And is there more we can do collectively so that we push this agenda and strategy much faster? Over to you.
Thank you very much. It's not an easy question to answer, really, because there is really not a good overview. But I think that Philip presented a lot of interesting proposals for how to move forward. I think it's not easy. I think governments need to come into play here. I think what they need is an understanding of what civil society can contribute with. There need to be a funding system for a sustainable action on the ground level. And on the global level, we have something called the Antibiotic Resistance Coalition, and numerous civil society organizations that are come together, incepted by ReAct many years ago, and are doing a lot of advocacy on the global level, having interactions all the time with major organizations like WHO and now also FAO and UNEP. But I think we need something similar on the ground level, and then need to be based in countries or even regions then. So how can we form, this will be more questions than answers, obviously. How can we form some kind of sustainable group or groups, an organization that could maybe apply for funding to become that sustainable engine on the ground level? Because that would be the real sort of way forward, to have something that is not just a short-term project, but is something that really engages civil society, learning by training, moving on, and also, not the least, maybe making use of this wonderful framework that was just presented, and using that in showing the governments where to go, what are the gaps, and how the country is improving. This is not really happening by itself. We have to self-organize. I think on the ground level, maybe start with this kind of community advocacy platform, but make that maybe some kind of cross-cutting civil society, maybe not organization, but at least some entity that could apply for some funding, and also some mandate taking part of the NAP implementation. Thank you.
Thank you very much, Otto. I'd just like to have a follow-up question to Nienke here. Of course, we know that the IACG has their strategies in place for this, as Otto mentioned. But we also know that the WHO has their strategies in place, especially with the Global Action Plan, the National Action Plans on AMR. And Anand alluded to that in his presentation. There's a lot of conversation now in the bottoms-up approach, but truly speaking, in a practical manner, how do you think we should actually further community engagement, and especially mobilization around NAP implementation? Over to you, Nienke.
Thank you, and I echo Otto, because it's a difficult question, of course. And yes, referring, and thank you everyone for excellent presentations. It was it's wonderful to see also the initiatives that were taken, and especially from the presentation from Philip and Haifa. Yeah, so Anand was explaining already a little bit about the people-centered framework, and I think that is also, now that we're moving to the National Action Plan 2.0, as we call it, countries have gained experience with trying to implement their National Action Plan, and came up with, or were, and of course there were many bottlenecks and challenges, but also we see that there's been progress. But also at WHO, of course, we've seen and learned about the process, and that's why we're trying to refocus into this people-centered framework. This is specifically the human health area that we're looking at when we talk about the people-centered framework, to really support countries now with their NAP 2.0 to better identify the needed intervention throughout this patient pathway that Anand was explaining about, but not just throughout that patient pathway, but within these different pillars, to look, okay, so which are the interventions that are required by the national governance levels, which are the interventions where community plays a very important role, and then come also, of course, the healthcare level, the primary healthcare and the secondary, tertiary healthcare levels, which, and then also have that interconnectivity between that. This all sounds very interesting, and but is, of course, at the same time quite complex. And then comes the challenge of translating this complex and need for many intervention into something that is understood also by government. So this policy-centered framework is really initially developed for policymakers to help them understand how and where the needs are. I think that is still a big issue, and we hear also from the presenters before us, that the understanding of AMR and giving AMR a face, that it's not a specific disease, that remains a big challenge, and attention as well. But yeah, I know I have limited time in responding. I hope this was a bit of an answer, but of course, we're still in the development of this people-centered framework. But we have to be fast because we know that many countries are now developing their NAP 2.0 and even 3.0, and there's already a lot of requests of this type of support. Yes, after this, I will continue working on this framework with my colleagues. And there will be also,
Thank you very much.
there will be a consultation also, of course, from external experts on this framework, and you will be invited, of course.
Thank you very much, Nikki. I'm very happy to know that consultation will happen soon, because
Yes.
I think this is the right time and a very important time in the world to get that going.
Yeah.
Can I just ask the next question to Lucy? Lucy, I know you're from the Wellcome Trust, and you've been a very important supportive agency, supporting all the antibiotic, not just the resistance work, but on use as well as R&D. But we also know that you have this very important project in Wellcome called the Responsive Dialogues Project, and I'd like you to just briefly mention about that. But also, what do you think would be the best way to improve this long-term commitment in terms of resources, in terms of engagement, especially among the low and middle-income countries, and with probably approaches such as the toolkit that we have. So over to you, Lucy.
Thank you very much, Sujith. So for the benefit of those that don't know, responsive dialogues and drug-resistant infections is a framework that gives guidance to bring different stakeholders within a community together to debate and respond to evidence about AMR and generate concrete practical steps to addressing it at sort of community and policy levels. Otto highlighted earlier the policy implementation gap, and this is very much meant to address this. So policy decision makers are involved, whether to observe, participate, or help set the framing of the conversation to align with policy interests. And in one of the pilots in Thailand, indeed, the dialogues have already been feeding into the development of the next national action plan on AMR. So answer to your question, how do we improve engagement, resources, and commitment to this kind of activity? Firstly, we need a greatly improved evidence base and the value to research, health, and economies of community engagement and community-owned solutions. One recent report found empirical evidence of engagement supports research outcomes, but we need so much more, frankly, and different types of evidence. What we do know is that, generally speaking, in terms of research, there is an inefficient model of working with communities where each new research project starts from scratch and researchers seem to come and go without any commitment to the community. So what do we need to address all this? Well, in terms of how we work with communities, we must have strong relationships. Trust was mentioned earlier, and it is critical. Communities themselves need ownership. Otherwise, there'll be an unequal power dynamic between science and community, which can lead to ethical issues as well as lack of motivation on behalf of community for participation. We need to build post-engagement activities in order to report back to communities, to work with them to identify ways and resources to implement their ideas. In terms of what funders can do to address this, funders can make community engagement integral to practice. For example, Wellcome are working with ICARs to enable a low resource version of responsive dialogues that can be adapted much more easily as part of ICAR's wider work with ministries of health. We need long-term sustainable investment in community engagement ecosystems so that the structures, knowledge, and skill sets are there. Community engagement doesn't happen by itself. And in terms of policymakers, integration of community engagement with existing policy processes is fundamental to the sustainability and success of the co-created solutions. So I think all these elements need to be built on in order to create more effective community engagement. Thank you.
Thank you very much, Lucy. I think a great follow-up question will be, if you're able to do this across the board or not. And for that, I just want to ask Samuel, who is in the Africa Voices Foundation. From what we know, you had this path-breaking project on the use of community radio stations, trying to spread awareness. Could you just explain what you did very briefly, and what were the key takeaways from your project, actually?
Thank you very much, Sujit, and for the invitation to this conversation. Yes, at Africa's Voices Foundation, we we strive to create platforms of engagement between citizens and decision makers and citizens among themselves. And we partnered with the GPSDD with the support of Welcome, and managed to execute this project in 3 counties in Kenya, where we used our core capability, which is using interactive radio, data and technology, research and design and analysis to interact with communities, basically to understand their knowledge, attitudes, and practices relating to AMR through the use of citizen-generated data, as well as to see how citizen-generated data methods increase policymakers and research communities' engagement with citizen data to inform AMR research as well as policies and decisions. And so we at these radio programs, we did 38 radio programs where we spoke to over 30,000, we spoke to over 5,000 citizens who sent us over 50,000 messages responding to questions that we had asked on air, with the help of experts in studio helping them to understand what we were talking about in simplified language. And so at the end of it, we got deep and nuanced understanding of community perspectives on AMR. We also heard from them on the drivers of AMR, but also they told us what they think can be done to tackle the problem. We have disseminated these findings widely, and we've also understood from the AMR focal point at the Ministry of Health here in Kenya that they will be using these insights to inform the new national action plan that is underway. And so what we did is really to catalyze and generate citizen perspectives on most aspects of AMR. And right now, we can say that decision makers, health service providers, and veterinary service providers have a clear and actionable insights on how to approach and tackle AMR among communities. Thank you.
Thank you very much, Samuel. Actually, another group, our sister group in Africa, ReAct Africa, has also done wonderful work, especially in various countries like Kenya. And Tracy, can I just ask you, I mean, what were the kind of factors which led to successful engagement of your communities there among the stakeholders? And I mean, is it easy to define success, or are we, just moving towards it rather?
Thanks, Sujith and the entire ReAct Asia Pacific team. I hope my network will sustain. It's misbehaving now. Anyway, so what stakeholders are we engaging with? All the way from policymakers through to students, just very similar to Asia Pacific. However, what are the engagement factors that we consider successful? Right from the beginning, as has already been mentioned, it has to be a participatory engagement. Yeah, right from the planning stage, it really doesn't make sense, bringing in especially new structural or even process aspects, yet we have working structure within the communities or within the stakeholder group that you're engaging. And before that, especially what we've seen in our setup, we really need to get a formal agreement with the national coordinating committees of AMR. That way, then it eases penetration into the subnational levels and to even the communities that you go into. So now when we go to the community, then we need to tap in right from the beginning, the key community stakeholders. So if it's in a school, the head teachers, of course, you've interacted with the Ministry of Education, for example, but then you're coming down now to the head teachers. If it's at a community, our chiefs are very influential. You need to bring them on board, religious leaders, et cetera, et cetera. So what does success in the community engagement really look like? It has been said before by the speakers, sustainable change long after we've exited. That even when we come back on ground, as I think Welcome Trust has mentioned, when we're coming back to actually sort of evaluate what is going on, even months or years later, we can see that whatever change we try to bring is already inculcated into the community, and the structural and process changes that we left behind, whether it's in terms of sanitation or just antibiotic use, is still very much present, and is being taken up right from the policy through to the household levels by the parents, by the children, and just through the community. So thank you. I know I don't have much time. I hope I've responded well enough. Thank you.
I think you have, Tracy, you've sort of put it spot on as to what I asked, and especially the success part of it. I'd just like to ask some very brief questions to all the panelists. I know we're a little short of time, but if you could, really spotlight some of these answers so that the participants can, get their minds stimulated and see further actions in their own region, as well as, some of the stakeholders they work with. And Otto, the first question is to you, actually. I mean, do you think that the resources for antibiotic resistance should, it's easy to say, you have only this much money and therefore, but the question is, should it go to where? I mean, how much should we actually devote to community engagement strategies, as for example, as compared to R&D, surveillance, or stewardship? It's a very tough question, but what are your thoughts?
It's a $1 million question, really. We have to do everything, but I think as we are short of time, the short answer is that there will be enormous cost effectivity in engaging society to bridge the gap between the government and professional organizations, the gap between governments and civil society organizations, and support them. I think that will make a change. So I think that is a missed opportunity, I think, in many countries yet. So I think just going there and trying to find, I mean, we tried it out 10 years ago. We got an extra grant from SIDA and tried to work with civil society organizations in Latin America, in Asia, and in Africa. I think it was too early. The issue was not up on the horizon like it is now. It's much easier now to train the trainers, make other NGO civil society organizations taking it up, but again, sustain in a sustainable way.
Thank you, Otto. Thank you very much. Ninke, we talked about the indicator framework, and Anand also made his presentation. Do you think these kind of frameworks are adaptable? What do you think will be the challenges when we start the work of putting in the ground?
I didn't hear completely the end of your question.
The indicator framework, the indicator framework, when we actually try and implement it on the ground in a large scale, do you think there'll be challenges, and what do you think will be the chief challenges?
Well, I think there's always challenges, because if there, the short answer is, of course, AMR is extremely complex, and I think one of the big problems in terms of, and I think I echo also what Otto was saying, and this is where these indicators will help to make the connection from government all the way down to the community, and this in a big part is communication, having knowledge understanding at all the levels, and having data to then be able to enforce the messages and the needs for investment and interventions. Then, of course, comes the what are the priorities and what should go first, but that also depends country to country. So yes, in terms of challenges of implementing in all countries, of course this can be challenging, and I think also it is when there's a great need and acknowledgement from the countries that this, I think that's the first step, that we really need to push that the community has such a vital part. So then, yeah, but it goes both ways, always. It's a chicken and the egg. I stop here.
Thank you very much. Lucy, I have a equally tough question for you. I'm sorry about that, but you know, most of many people have this perception that engaging the community is quite a difficult exercise, and of course, it could be a black hole in terms of funding. But how do we actually, how do we think? What are the key points that to make it more palatable for funding agencies and governments that this is a worthwhile exercise to to engage with communities?
Well, I think briefly, it's very can be seen as a very long, drawn-out process, community engagement, but actually, in our experience, often it needs to be even longer and deeper, which makes the value of the outcomes, demonstrating the value of the outcomes, ever critical. We also need a more sort of sophisticated approach in exploring the benefits of community engagement that isn't just about numbers, but is communicable. We need to identify sort of clear policy areas where community engagement can bring focused solutions, and in particular sort of national action plans, really addressing the AMR implementation gap. So thinking about all of those, I think really through evidence and advocacy, we need to create a sort of mindset shift around the value of community engagement. So in the longer term, it is more immediately palatable, automatically adopted. I hope that briefly covers. It's a very difficult question to answer, but I think that pretty much in summary addresses what needs to be done.
Thank you. Yeah, all these answers I know are, the questions are tough and the answers are, to put it in a brief manner, is difficult. But I think it's very important that all of us, especially the participants and the wider community, thinks about this, because unless we actively engage these areas which we're talking about, it's going to be very difficult from a sustainability point of view. Samuel, your question is actually, you mentioned about these SMSs and the messages. I mean, what are the tips to get these frameworks of messages right? I mean, what are the messaging frames which really work with communities? Any tips on that?
Well, I think the answer to that could actually be what we heard from the communities themselves. And I think what they told us, it relates very much to issues of education, that the community needs to be educated on AMR, that there are regulations around drug selling and dealing, and which is not properly enforced. And so there are many loopholes with many members of the community being able to access the drugs over the counter, and that's without prescription. And also the need to improve hospitals, because many of them do say that the hospitals and health facilities are under-resourced, and then they are forced to go and buy medicine. They might have to buy it with a prescription, but they may not be able to afford a full dosage of the medication. So I think looking at this, then we can easily see the ways in which we can communicate so that the communities understand better how AMR develops in human beings, in animals, in agriculture and the environment, and that they can also relate to how these affects their children in particular. I think when we were engaging with the focus group discussions, the mothers could, for example, easily identify some popular brands that are common in the chemists based on the ailments they treat. And they could also tell whether these were antimicrobials, and also some could relate to cases where drugs that used to work for their children were no longer as effective as they used to be. So even though they may not easily understand what AMR is, at least they can see the effect of it, and also made contributions in terms of how they can be supported to address the issue of AMR through their own everyday life experiences.
Thank you, Samuel. That is very clear. Tracy, last question to you. Of course, humankind has always had problems right through its existence. And one of the things which happened a few decades ago was HIV/AIDS. And there was a lot of community engagement in that area at that point of time, and still is. are there any lessons to be learned from that? And can we translate and replicate some of the aspects of community engagement to antibiotic resistance?
Short answer, yes, we can replicate. There's some, quite a number of successful engagements, but this all boils down to trust. The community has to associate us, the people bringing about the intervention, with trust. So good examples in our setup was the use of community health extension workers, as I know also in Asia is quite common. And in this case, they were actually going last mile, delivering the ARVs to the communities, including the pastoralists, who still to date have a very high stigma index when it comes to HIV. But because the drugs are being taken to them, and not only just delivering the drugs, but also these community health extension workers are building capacity, even as the days go by, to these patients, if I may call them that. And so that way then, because of that relation that's built and the trust, any other aspect that you bring on board, whether it's, this difficult faceless AMR and the use of antibiotics, then they're able to actually take it up slowly and understand the role that they're playing, whether it's in their farming or even as they give their children antibiotics, what role they play in making this non-renewable resource, extinct, if I may put it that way. Another example is where not too long ago, just before COVID, this one implementer NGO went with this notion of building not for HIV, that is, but for putting a 10,000 liter water tank in one of the areas. The community really wasn't interested in this. What they were interested in is food. They wanted food. They wanted to know how they can be getting money to sustain, and get a sustainable source of food for their community, for their children, for the women who are being left behind by the men who are going to the urban areas to look for better pay and jobs. And so what they actually did is to put about 3-4 community extension workers there who lived with them for about 6 months. Of course, that is cost intensive, but then they were able to get their trust and able to understand what the community really wanted, because they didn't want the 10,000 liter water tank. And this actually, the long and short of it is that now, eventually they've been able now to start drip irrigation, and so the water is coming from a nearby source of a seasonal river, but they're able to get their food. And now the NGO is able to bring about now the aspect of health to this community. So trust and engaging them right from the beginning, very key. Thank you.
Thank you very much, Tracy. And I think that last two key words, trust, engagement is going to be crucial, I think, if we need to move forward in a holistic view with our antibiotic resistance issues, containment, and above all, moving forward to a world free of, fear of infections. So thank you very much. And I think we're going to the last part of our webinar, where we're concluding, and Shruti, over to you to just talk about that as the last few minutes of this webinar. Thank you.
Thank you. Thank you to all the panelists and our moderator. That was a very informative session. Next, we have Mr. Satya Shivraman, Communications Coordinator, ReAct Asia Pacific, summarizing the key takeaways and conclusion. To you, Satya, sir.
Thank you. Thank you, Shruti, and thanks for a very rich presentations and discussion throughout this evening today. I will not summarize what has been said already, but try to draw some very broad conclusions. One is very clearly what has come through is the problem of implementation. So you have global action plans and national action plans, but implementation has been a challenge. And the Antibiotic Smart Communities was a response to that. That how do you break up a national level plan, which is very remote, and make it meaningful to communities on the ground? How do you get communities to understand what is required? Now, having done that, it led to the challenge of understanding what exactly is a community. As was mentioned earlier, by one of the speakers that communities can be a wide range of things, and also communities exist in a wide range of contexts. So there are many communities. So the primary task of community engagement is to first understand the community, that is to go to them and listen to them. And that's where trust would come in. The point about trust is very important. And I think one of the ways by which trust happens is not to parachute into a community with some resources and tell them that they need to change, but to spend time with them and to be able to win their trust. And here I would say that one of the challenges of AMR has been mentioned by all the speakers, that it's a complex issue. But the challenge of implementation is compounded by the fact that we are approaching it largely as a medical subject, as a subject of rational use of drugs, as a problem of health, which all of which it is. But the inadequacy of this, because when you have a problem with implementation, there are two ways of looking at it. Either you're not doing enough to implement it, there's a shortage of resources, or your approach may be slightly off the mark. So that's where the social, cultural, anthropological aspects of understanding communities. And because people have belief systems, and medicine is very ancient in human societies, and people have very strong views of what works, what doesn't work. And it's not necessarily based on the papers they read in the Lancet. It's based on folklore, it's based on local traditions, and so on and so forth. So understanding the community comes across as a very important point. But having said that, the other point that comes through very well in the discussion today is that engaging communities is not going to be sufficient, because communities are also quite disempowered. In the LMIC context, to go to a typical community in Kerala, as Philip pointed out, this is one of the most well-off communities in all of India. So they scored quite highly, when all the indicators were measured. But most communities don't have even basic running water or access to food, as Tracy mentioned. So you need to be able to have a mechanism by which whatever you're doing at the community level is also conveyed to policymakers, decision makers at different levels. It could be at the regional level itself and onward to the national level. Here, I would like to point out that one of the ideas that we had right at the beginning, before we ventured on this Smart Communities project, and Philip made a mention that this list of indicators was actually meant to help compare one community with another. So these are not absolute indicators in the sense that we're not trying to get communities to score 100 out of 100 along all these indicators. That would take too much time and too much resource. The idea was to develop a competitive structure, a friendly competition. So you rank different communities, and then you are able to, feed into this natural need among people to be able to rank themselves against others. It's not a new idea. The greening of cities, including UN organizations, have been doing this kind of thing. But in the context of AMR, I think the resources that are required to scale up a community level intervention like this is to get resources to be able to give awards. If we study 10 communities and rank them, then the best couple of them or best 3 of them should get awards. It's an incentive thing which propels communities to improve their indicators on their own also. Because while policymakers and governments are important, we know the standard thing about why NAPs are not being implemented. There's always a claim that there are not enough resources. And resources are not just in the context of AMR, but because AMR is linked to health systems in general. You don't have access to hospitals because you don't have hospitals. You don't have access to medicine because there's no money to buy medicines. So in that sense, the resource mobilization is somewhat mitigated if the communities engage in self-help. So the importance of community engagement is not as passive recipients of advice and training, but to tell them that in the context in which we are in a typical LMIC, they will need to do a lot of self-help to improve their conditions. And here, I think the other thing that came through very well was that AMR is not a standalone issue. It is closely linked to, I mean, Otto referred to the paper that ReAct published on systems approach. It's very closely linked to the larger health systems. So it is these indicators, in a sense, they capture, there are 15 of them. Originally there were 34. And these 15 are succinct and easy to use. But I suppose when these kind of experiments or pilots are adapted across the region or across contexts, you might need a few more indicators. So that list of 34 is still perhaps relevant to draw upon if needed. With that, I think I will, and the most important point I think that came through as far as I was concerned was the presentation by Dr. Balachandran about the WHO's people-centered approach. And the framework that they've come out with is very, very interesting. This is, one is that looking at the individual level of treatment, diagnosis, access to health service, but also linking it, or rather individual behavior level issues or access to sanitation and wash facilities, but linking them to the larger systems issues. I think the pilot that we have done in Kerala would benefit a lot by trying to look at this people-centered framework and see how we can contribute to that framework in strengthening that framework, because I think these are very, very complementary processes. And that framework is absolutely brilliant because it's so comprehensive. Thank you.
Thank you so much. Thank you, Mr. Satya, for those very clear and important messages. And finally, thank you all for being a part of the webinar. We have a short video on the Antibiotic Smart Community efforts that we have taken in our pilot site in Kerala, India, after which we'll be closing the webinar. So thank you all once again.
To Uppsala and have a mingle and then a dinner. Is that correct? On the first day, on the 6th of March. Okay. And then you mentioned the University.
So the Global Action Plan on Antimicrobial Resistance and the subsequent national action plans which came out since 2015, there's a wide perception that most of them followed a very top-down approach. And the local populations or the community stakeholder groups were not co-opted into the process. So what we were trying to do as a part of Antibiotic Smart Communities project is to kind of include a local community in the state of Kerala, India, on designing and implementing action on AMR. So we kind of engaged that particular community for a long period of time, almost 5 years, and used that learnings to actually design a multi-parameter indicator framework to measure antibiotic smartness or antibiotic AMR preparedness, I would say.
ഈ കോവിഡ് കാലത്ത് ഈ കമ്പ്യൂട്ടറും ഗ്ലൗസും കിട്ടിയത് ഏറ്റവും വലിയ ഉപകാരമായി പോയി ഞങ്ങൾക്ക് എല്ലാവർക്കും.
2018 onwards, ReAct Asia has been cooperating with us in raising antimicrobial awareness program. We have been getting the support of local self-government, Mallappuzheri Grama Panchayat, and NGO Mallappuzheri Grama Vikasana Samiti, and also Kudumbasri units. The ReAct Asia has been working with the existing framework, and we could generate a community ownership in this program.
ഞാൻ ഇതിൻ്റെ 2 മീറ്റിങ്ങിൽ പങ്കെടുത്തു. അതിൽ ആൻറ്റിബയോട്ടിക്കിൻ്റെ ദുരുപയോഗം, അതായത് കൂടുതൽ ഉപയോഗിക്കുന്നതിനെ കുറിച്ചുള്ള ക്ലാസ്സുകൾ കേട്ടു.
ആരോഗ്യ എന്ന ആശയം സംസ്ഥാനം ഒരു അജണ്ടയായി ഇക്കാലയളവിൽ കണക്കാക്കുമ്പോൾ പഞ്ചായത്തിൽ ഇത് നടപ്പാക്കിക്കൊണ്ടിരിക്കുന്നു. ഞങ്ങൾ ഒരു പിടി മുന്നിലാണ് പ്രവർത്തിക്കുന്നത് ഓർക്കുമ്പോൾ വളരെ സന്തോഷമുണ്ട്. വർഷങ്ങളായുള്ള തുടർപ്രവർത്തനങ്ങളുടെ ഈ ചിന്താഗതിയുടെ പ്രാധാന്യം മനസ്സിലാക്കുവാൻ സാധിച്ചിട്ടുണ്ട്. തീർച്ചയായും ഞങ്ങളുടെ ഭാവി പരിപാടിയിലും രോഗപ്രതിരോധത്തിനും ഏകാരോഗ്യത്തിന് പ്രത്യേകം പ്രാധാന്യം നൽകുന്നതാണ്.
As a part of the Antibiotic Smart Communities project, we have published this indicator framework. We have published several strategy documents on optimal messaging frames, on how to do a situation analysis, a toolkit to engage community stakeholder groups, and a lot of things actually.
Thank you very much to everyone. Thank you very much to everyone, and we hope you enjoyed this webinar. And we hope that this is the start of great things in terms of community initiatives and engagements. Thank you to all those who organized this. Thank you very much, and good night.